Well, we know historically that patients who come off chemotherapy and undergo active surveillance will almost invariably have a recurrence. And we know from the most recent work with PARP inhibitor maintenance therapy that patients who received placebo have a recurrence on average about 5.5 months after completing chemotherapy. So the outcome of these patients with active surveillance is really not very good. And the PARP inhibitor studies have shown that those patients who go onto a PARP inhibitor after receiving platinum-based chemotherapy have a significant prolongation in their progression-free survival. So it delays the time before further treatment is needed. And in some patients, this delay is considerable to the point that it improves overall survival. And about 11% of the patients in the first trial that was done, the Study 19 trial with olaparib, we saw that about 11% of patients are long-term survivors without any evidence of disease progression. There are 3 PARP inhibitors that are licensed for use as maintenance therapy within the EU: olaparib, niraparib, and rucaparib. And the results of the clinical trials of maintenance therapy with these 3 drugs have essentially been very similar. They've all looked at different groups of patients, both with or without BRCA mutations, and it's very difficult to distinguish those 3 drugs on the basis of efficacy. There are, however, some differences in the toxicity of these 3 drugs, and this may be important in relation to treating patients and in familiarity with the use of these drugs amongst clinicians. So, for example, the commonest toxicities of fatigue are seen across all 3 PARP inhibitors. Nausea is more common in patients receiving olaparib and rucaparib than niraparib, but on the other hand, with niraparib, there's a greater degree of myelotoxicity, thrombocytopenia, and neutropenia compared to the other 2 PARP inhibitors. Anemia, however, is seen equally across all 3 PARP inhibitors. So there is a difference, therefore, in the spectrum of these side effects, and there are 1 or 2 other small side effects that are sometimes seen with some of the individual PARP inhibitors, such as niraparib, may cause hypertension, and rucaparib may cause an elevation in the liver transaminase, although this is not clinically significant. But by and large, the 3 PARP inhibitors are similarly tolerated, although in the clinical trials, there were a greater proportion of patients requiring a dose reduction with niraparib and dose continuation with niraparib compared to the other 2. Having said that, more recent data with niraparib using a lower dose in patients who have a weight less than 77 kilograms and a lower platelet count at the initiation of treatment has led to a much lower reduction in either further dose reductions or discontinuation. So as we become more familiar with PARP inhibitors, we can manage their toxicity better. And the vast majority of patients are able to continue treatment, managing the toxicity during the course of treatment. The initial work looking at the effectiveness of PARP inhibitors in women with recurrent ovarian cancer was performed in patients with a BRCA mutation. And at the beginning, it was felt that this was the group of patients who would benefit. But it soon became clear that many patients without a BRCA mutation may also benefit from PARP inhibitor therapy. And all of the 3 trials with rucaparib, olaparib, and niraparib have included patients both with and without a BRCA mutation. And what we see is that the magnitude of benefit with PARP inhibitor maintenance therapy is greatest in those patients who have a BRCA mutation, either germline or somatic. But we also see across all 3 drugs significant benefit, significant clinical activity in patients who do not have a BRCA mutation. And for this reason, all 3 drugs are licensed within the EU for maintenance therapy, irrespective of the presence of a BRCA mutation. Progression-free survival is the endpoint that's historically been used to evaluate PARP inhibitors and indeed many other new drugs in the treatment of cancer. And this is a very clearly defined endpoint in relation to progression on imaging. But for patients, what's important is the length of time from finishing their chemotherapy until they have to start another line of treatment. And we've looked at this within the PARP inhibitors and measured what is called the time to the first subsequent treatment. So this is the time from the initiation of the PARP inhibitor therapy to the time that the patient restarts another round of treatment. And what we've seen is, for all the PARP inhibitors, that there is a prolongation beyond progression-free survival in patients who have had a progression. That is to say, immediately after progression, they do not always start another round of treatment. If we look at the SOLO2 trial, the time to the first subsequent treatment, comparing placebo and patients on olaparib, there's a 20-month difference. So one can say to patients that by taking maintenance therapy, it is likely that the next round of treatment will start on average 20 months later. And that's a significant improvement. We've also seen in one of the trials where overall survival data are mature, with the Study 19 trial of olaparib, that there has been an improvement in overall survival. Now, this does not reach statistical significance. The trial was not designed to show differences in overall survival. But what is interesting is the observation that after 3 years, there appear to be few, if any, further recurrences, and those patients are continuing to on treatment and have a survival advantage compared to the control group. So I think as we move forward with PARP inhibitors, we are likely to see a small but definite survival advantage appear with maintenance therapy from PARP inhibitors.